means is that the macula is not functioning properly. So when you look into the patient's eyes, you will see signs consistent with diabetic retinopathy, especially since this is a patient that probably already has diabetes, or labs consistent with diabetes, and you'll see that the macula is affected. Diagnosis, an ophthalmoscopic exam is the first test, and that will show abnormalities. It will show the hard exudates and the hemorrhages in the area of the macula. Then optical coherence tomography, as I mentioned, is more accurate, and that can show you the macular edema that's consistent with diabetic maculopathy. So here's diabetic maculopathy. This is the macula right here, and you see hard exudates on the macula. So the macula is affected. Unlike the previous pictures I've been showing you, the macula was not affected. Here's some more. And this is the optical coherence tomography. This is the macula that you're looking at right here. And this should be flat up against the layer deep to it. But you've got fluid collecting up beneath the macula, and that's what's causing the symptoms. This is macular edema. And pretty much always macular edema accompanies diabetic maculopathy, but it can be difficult to see macular edema just with your ophthalmoscope, unless you're a master ophthalmologist. So this is a good way to confirm your diagnosis. If you have a picture like this one that doesn't necessarily show a whole lot of abnormalities on the macula. Most ophthalmologists will do this test in patients that they suspect maculopathy. So the way this is treated is by laser photocoagulation. Sometimes they use intravitreal VEGF inhibitors, or they can use vitrectomy if there's consistent problems with bleeding. But diabetic maculopathy is primarily treated with laser photocoagulation. And as usual, primary prevention will continue to be important in these patients. Proliferative diabetic retinopathy is the most advanced stage of diabetic retinopathy. In this case, native vessels have endured damage to the point where new vessels are forming. And proliferative diabetic retinopathy is characterized by neovascularization, and that can occur anywhere from the optic disc to the major vessels and beyond. Hemorrhaging is very common, microaneurysms, dot blot hemorrhages, and vitreous hemorrhage can be present as well, or it may also be the presenting symptom in some cases. With continued vascular proliferation, new vessels can progress to the anterior structures and can block the angle of the eye. That can lead to glaucoma. Dead vascular tissue can fibrose and can act as a source of traction, and that can lead to tractional retinal detachment. The symptoms of proliferative diabetic retinopathy can be blurred vision, and that can be either from vitreous hemorrhage or macular edema. Floaters, and that can be from if there's any kind of vitreous material or any blood or material in the vitreous, that can cause floaters. Difficulty with nighttime vision. Symptoms of complications can be present. So if you have retinal detachment, you can have photopsia, floaters, visual field deficits. If you've got neovascular glaucoma, and there's pain, photophobia, and you can see neovascularization of the iris, and then you can also see conjunctival injection. Like I said, we're not going to talk about these complications. We talked about retinal detachment. We'll talk about glaucoma pretty soon, where I'll address neovascular glaucoma. But these are some of the complications that can come up. And with proliferative diabetic retinopathy, you can have symptoms of complications of presentation. So the way to diagnose this, of course, is through ophthalmoscopic examination. And typically, patients with diabetic retinopathy, we're doing an ophthalmoscopic examination on them every year, or the ophthalmologist is. And so we're charting their progression. And that ophthalmoscopic examination is necessary to establish the diagnosis, along with other tests like visual field tests and acuity exams. Another thing that can be done is ocular tonometry if they show signs of of glaucoma, that measures the intraocular pressure if glaucoma is a concern. The treatment for proliferative diabetic retinopathy is pan-retinal photocoagulation. And this tends to be the first line treatment. However, other things can be done, especially this new treatment it came out within the last 10, 15 years at most, and that's intravitreal VEGF inhibitors. And what you're doing is you're injecting VEGF, which is a product that inhibits vascular epithelial growth factor, and by doing that, you will inhibit the growth of new vessels. And so this is an injection that's put into the vitreous. There's another, I'm trying to remember it, is triamcinolone, which is a steroid. That can also be used, but usually the intravitreal VEGF inhibitors are used if you're using medication. But pan-retinal photocoagulation, I would say, would be your answer on USMLE if you get a question like this. So this is proliferative diabetic retinopathy. You can see here you've got what look like those loops here, and then here coming out from that, you've got neovascularization. And this is pretty close to the optic disc. And of course, you got bleeds, dot blot hemorrhages. This is severe proliferation. It's another one. So you can see there's a locus of proliferation, neovascularization here, neovascularization coming out of the optic disc. But the macula is spared here. So here's proliferative diabetic retinopathy with a vitreous hemorrhage. So this is a patient that may present with a gradual blurring of vision because they're looking through blood. Here's a fibrous band. This fibrous band is just dead tissue that can show up with diabetic retinopathy. And the problem with these fibrous bands is as you're turning your eyes, these can be points, traction points, where you can get retinal detachment. And retinal detachment is a whole other animal that's treated in a totally different way, but it's very problematic when you have diabetic retinopathy because the retina is already fragile. So you don't want this. This is diabetic retinopathy, but this is in a patient who has had photocoagulation performed, and that's what these little white spots are. They're just scars from the laser. Notice that they, of course, went around the macula because you photocoagulated the macula, and you have no vision. So went around the macula here. That's why this area is not done. So further management, remember that patients with diabetes mellitus are at increased risk for other ocular problems besides just diabetic retinopathy. There is also an increased risk for cataract formation, as well as thrombosis to the retinal artery. All patients with diabetes should have blood pressure and lipids monitored. Remember that blood pressure increases your risk of clots and atherosclerosis, and atherosclerosis and clots will increase your risk of thrombosis to the retinal artery. And they should also have their lipids monitored for that reason too. And of course, any adult patient in general should have those things measured, but it takes on more importance in a patient with diabetes. A hemoglobin A1C is the best way to monitor patients' long-term compliance, long-term progress with their diabetic regimen, and we prefer to have these patients between 6 and 7%. Smoking reduces retinal oxygenation and may upregulate VEGF, so that would accelerate progression to or of the proliferative disease if they already have it. So stopping smoking is always a good idea, but particularly in patients who have diabetic retinopathy, we want them to stop smoking so they don't start making more VEGF and putting themselves in the proliferative disease. Also, since we're talking about diabetic patients already, beware of prescribing the thiazolidine diones, TZDs. Why we want to avoid these? Because they are associated with an increased risk of macular disease. So we would prefer to have the patient